It's always hot in here. Why is it always hot in here?
This room is bipolar.
It is. I've been told this room is linked to the lab down the hall. And
like Nobel.
this room gets to be miserable, so that room can be comfortable. That's what I've been told.
That room is often very cold. Almost like
This whole building does not have adequate temperature control. And I learned a long time ago these thermostats do have solutions.
it's just the way it is. One more week.
It's going to be a rough one
I know.
for me. I have so much to do. Dr. Grant, I don't know how we're going to get everything done.
You're not like scuba diving.
Yeah, it's hard.
You have like swimming on the top of the water, and you kind of go up a little bit, but like and then just sharks everywhere. It was so cool. But then one got like way too close to us.
Last section.
Yeah, like, but that was really cool. So we went and did it like 5 times that one day. I get home and it's over here. It is. I love it. I want to like touch
Open.
But that's what I loved about Hawaii is like when I just went to Hawaii, like as a kid, you just grab onto the turtle shells and then the turtle would kind of hold it for a second and you have to let go because they'll turn around and bite you.
Yesterday,
But we did that when I was like,
they added to it.
I've been to Hawaii like 5 times, and every time we're swimming with sea turtles. It was just so cool. Yeah.
So nice. I don't know the farm yet. I need everywhere.
How many days are you first?
I think that's like
In 4 days, there's an off-site. So if you're going to do your stuff, let's see. I don't remember what it's called.
And then 4 days, I don't think they're all next to each other, but 4 random days, like one from zero to like your secondary location.
They are pretty clear.
all concerned about
We have 5 days.
Yours is also a lot longer to get there.
We're going to be there 5 days. So we fly to Turkey, and we fly from Turkey to Mozambique. And then we're just staying in Maputo. And then they were going to split us up into 3 different cities. They're like kind of further away from each other. One of them is like an hour or 2 hour flight.
Like split you guys?
No, no. You have a mission And then
somebody. I submitted
ethics.
not this week, it's next week.
Then we
Library?
Or does he have we have
Yeah, it's not really
like
good.
and we have like a chapel. So we're gonna have like a good morning. And then we all wear like and then we have there's different like hotels. So the first place we're staying at places
So tired. grab a tissue.
Oh, yeah.
I still didn't even get all my. Or my cookies.
It went by pretty fast.
That's like one of my favorite teachers.
We did our part.
What was that? That's a great way to start the morning. Let's bow our heads for a word of prayer. Gracious Heavenly Father, we are so almost done with this quarter. It has been a very, very busy quarter for these students, and I pray that you will give them that little extra oomph that they need to finish the quarter, finish all of their final exams, and do a really good job. I also pray that you will be with them during the break and give them the rest that they so desperately need. I pray these things in Jesus' name. Amen. We are on our last topic for the quarter. It is a 2-hour topic, so we're going to do 1 hour today, and then we do 1 hour on Friday, and the rest of the time on Friday we have for review. I chose this topic to be last because a lot of it is review for you already. It has things in it that you have studied elsewhere and that you already know. And I thought it would be nice if our last topic was kind of kicked back and didn't have a lot of new material, because we kind of need that. Our brains are full and overflowing, and we don't really have room for much more in there. So we are talking about abnormalities of teeth. A lot of things that are familiar to you. Because things are familiar to you, I'm going to go kind of fast. If we get to something you haven't studied before, let me know and we'll slow down. So we'll go as fast as we need to and as slow as we need to according to what you think you want to know. We are going to look at abnormalities of teeth in groups of alterations. We are going to look at those things first that have environmental influences. Environmental influences that could have been present while the teeth were developing. Environmental influences that affect the teeth after they develop and once they are erupted. Those things affect tooth structure as well as the color of teeth. And then we are going to look at the numbers of teeth and size and shape of teeth. But we're also going to look at a few genetic things that are not of environmental origin. And those are things that you might not have studied before. And those are the ones we'll talk about on Friday. There aren't very many of them that we'll talk about, but there are a few important ones you should know about. So we are going to start our discussion with environmental effects on tooth structure development. That means these are all disorders of teeth that happen while the teeth are developing, but due to environmental influences. So they are as early as in utero influences or after birth, but the teeth are still developing. Do you remember your timetables for development of teeth? Good, because that can be very helpful in interpreting the changes that we see to help us understand if these are developmental in origin, possibly environmental or not. We are going to start with enamel hypoplasia. So what does hypoplasia mean as a word? Hypo always means less than, but what does plasia mean? Growth. It means growth. So hypoplasia, enamel hypoplasia, means that we have missing enamel because the enamel matrix did not grow during tooth development. Enamel hypoplasia can be genetic in origin. That's pretty rare. That's one of those rare things that we're going to talk about on Friday. So most of the time that we have enamel hypoplasia, it is due to an environmental influence during tooth development that temporarily or focally shuts down growth of the enamel organ. So we don't grow the matrix. Anywhere we don't grow matrix, it can't calcify, and we get a different shape because we're missing some of the enamel. Sometimes, depending on the nature of the problem that caused it, we can get pits that form in the teeth or rings or grooves. That's the typical type of thing. Would you expect in environmental origin type of enamel hypoplasia to affect all the teeth and the entire tooth? No. That's correct. You would not expect that because you wouldn't expect an environmental influence to be present for that kind of duration, because it takes months to years to form teeth, and we don't usually have that type of adverse environmental influences. So these are usually localized problems. This is a child who has loss of the tips of the cuspids and about half of the incisors that were primary. The primary lower incisors are already gone, and you'll see that the permanent teeth are normal and the other primary teeth are normal. So those anterior primary teeth are the first ones that form. They form in utero, and this was something that influenced them in utero. Unfortunately, there's also some decay on that because there wasn't enough enamel to protect the dentin, so we have some decay, but the initial problem was enamel hypoplasia. Perhaps the mother was very ill for a short time during fetal life, during that little window of growth of those teeth. And so we ended up with some focal enamel hypoplasia. There are certain viruses that mom can get that are notorious for causing damage to the developing fetus and can affect the teeth as well. But we don't see that one very often. This is one of the more common patterns of enamel hypoplasia, where we have just one or two teeth affected and it's a ring of involvement or a round spot, and that can be caused by local environmental changes. This is a permanent tooth which forms after birth. So Turner tooth or Turner's tooth, where it's just one or two adjacent teeth, is often due to infection of the primary tooth that causes some damage to the follicle, or maybe trauma that causes some damage to the follicle for the permanent tooth, but it's very localized, either a round or oval area or a ring around the tooth. When we see this pattern where we have areas of missing teeth, tooth structure on the areas of teeth that are forming at the same time, tips of the cuspids, incisal edges of the upper incisors, more middle, a band of middle area on the lower incisors that develop a little earlier. That tends to be due to an illness in the child that was associated with a high fever. A really high fever can cause temporary cessation of growth of the enamel matrix, and we can get those bands of missing enamel on all the teeth that it would be forming at the same time. So just depending on the time of the illness. Do you notice in this picture that the permanent first molars have stainless steel crowns? And that's because they're forming at the same time. The occlusal tops and cusp tips. And they were so damaged that they had to be protected. And so stainless steel crowns were placed. So do you think you can figure that one out, enamel hypoplasia? All right. So now we move on to enamel hypocalcification. In enamel hypocalcification, the enamel matrix forms properly, so we don't have any alteration in the structure of the tooth. The size and the shape are normal, but we have areas where the enamel matrix doesn't properly calcify, and when we don't get enough mineral deposition, it makes the enamel chalky. It makes it more opaque when we have a poor crystalline structure. And those are usually localized effects, often just a few teeth here and there. This is a pattern where it ended up just being a few little places. And we can actually get enamel hypocalcification in localized areas of permanent teeth for the same reasons we actually get enamel hypoplasia, just not as severe effects. So maybe infection of the primary tooth in that area can cause some enamel hypocalcification. But those can be a little bit challenging to treat. This patient has extensive changes in the coloration of the teeth with a lot of opacity and some brown discoloration, and it's pretty much generalized. That is hypocalcification from excess exposure to fluoride during tooth formation. There's a name for that, and you have studied it.
Fluorosis.
It's called fluorosis. What is the rule that we have learned all quarter? You always use the most specific diagnosis that applies. So if I show you a case of fluorosis, don't tell me enamel hypocalcification. You're correct, but you're not specific enough. So you should be able to tell when it's fluorosis because it's generalized. And it's mostly white. And I have some more pictures of fluorosis. So we'll come back to that one. Did you learn your levels of fluoride exposure that cause fluorosis? Because probably one of your courses you had to learn that. Yes? No? Oh, okay. Usually you guys do. If not, you have it. Up to 1 part per million of exposure through water and foods and things is ideal for enough fluoride to be incorporated in the enamel crystalline structure to make the enamel very strong and resistant to decay. Because people get multiple ways they're exposed to fluoride, the federal government changed the levels of community water fluoridation to 0.7 parts per million. It used to be 1 part per million. So 1 part per million is the max of ideal, but because we can get exposure through swallowing toothpaste or other things, community fluoridation is not allowed to be more than 0.7 parts per million. If you get too much, it does affect the teeth adversely. And most patients who have fluorosis have mild fluorosis, not more than 2 parts per million exposure when the teeth are forming. And so they just get some mild chalkiness, that diffuse, mild, increased opacity, sometimes mottled, not uniform, sometimes mottled. But with higher levels of fluoride exposure, we can get brown discoloration, and in very high levels of exposure, we can even get some enamel hypoplasia. The amount of fluoride can actually affect growth of the enamel matrix. You have to work really hard to have that level of exposure so we don't see it very often. Are you likely to see a lot of fluorosis in areas that have community water fluoridation? No, because those are areas that have naturally low water levels of fluoride, and so most people don't get very much. So where you're likely to see fluorosis is in areas that have naturally high levels of fluoride. Fluoride is a natural mineral that is present in the water in a lot of places. Does anybody know what our fluoride levels are here locally?
The school?
In this general geographic area. They're pretty healthy levels. They may even be over 1 part per million. So I was born in Loma Linda when my family lived in Riverside. We moved from Riverside to Grand Terrace when I was about 2. Then we moved to Redlands. I've lived all over in this area. My sister's 15 months older than me. She has very mild fluorosis. She even has some pitting on her teeth, like very, very slight little divots. And I didn't get any of it. So I've decided Riverside water has has more fluoride than Grand Terrace and Loma Linda and Redlands water. Grand Terrace gets their water from the foothills. It's as good as Arrowhead bottled water. It's awesome water. So I have better teeth than my sister. If you live out in the desert, in our local high desert, and you have well water, the well water in the desert in this area has high fluoride levels, and we see a lot of fluorosis and some of the really bad fluorosis cases from people in this region who grew up on well water. So there are varying amounts of fluoride, and if you think your patient has fluorosis, ask them where they grew up, ask them if they drank well water, public water, bottled water, whatever, and you can find out some interesting things. These are some examples. Which of these had the least exposure of fluoride? Probably the upper right, maybe the upper left. The other ones is pretty significant. So all of these are more than 1 part per million. All of them are pretty much over 2 parts per million. Look at this one. You can even see the pitting. There's some pitting there as well. So these are a little more severe. What would I expect you to be able to recognize in a patient? If you can't recognize it till it gets this chalky and has brown, you're missing the majority of your patients. So you should be able to see the minimal chalkiness like this without the brown. I think that's appropriate for you to be able to have a suspicion for fluorosis. But it's going to be very generalized. Almost always is very generalized. How do you tell, I'm going to back up. How do you tell fluorosis on a child in particular apart from enamel decalcification, which is the early process for caries development? So they're both white and chalky. I saw a child yesterday, 2 years old, almost every tooth in the mouth was chalky, and you touch them with a burr and it just goes to powder, so demineralized.
Caries.
And that's all caries. So how do you tell that apart from fluorosis? Fluorosis is hard. Caries is only the part of the tooth that's exposed to the oral environment. So push down the gingiva, and it's going to be normal. No chalkiness if it's caries or enamel decalcification from acid in the mouth. So you can always tell. If it's fluorosis, you push down the gingiva and the tooth looks the same. It's still mottled because it was developmental in origin. I have parents all the time tell me, my child's teeth erupted like this. And then you push down the gingiva and you show them, they don't like that. You just got rid of their excuse. All right, we are going to move on to post-developmental loss of tooth structure, meaning that the teeth formed properly, but after the teeth erupted, we have lost tooth structure. What is the most common cause of post-developmental loss of tooth structure? Caries, absolutely. This course is not going to test that or cover that, but you got to know that. So we're looking at the other types of things. And unfortunately, the common other types of things are often present simultaneously, and it can be a little bit difficult to sort them out. One of the most common ones is ordinary attrition, tooth to tooth wearing away. So we see it first with wear facets at contact areas, and then they get broader and broader. It can be generalized, it can be localized, where we have teeth in malocclusion, that are in the wrong position, so they have abnormal wear patterns. A person who has ideally positioned teeth and normal function gets minimal wear. Things that accelerate wear are abrasive diets, of course malocclusions, and habits like grinding the teeth. Bruxing definitely accelerates it. Once we get into dentin, which is much softer than enamel, it can wear away even more. But one of the characteristics of attrition is that the wear areas are flat. They're flat. They're not curved. They're going to be flat planes. So this is worn flat. And sometimes it's flat and angled, but it's worn flat. Is this worn flat? No. No, it's not. It's cupped out. It's cupped out. Once you get exposure of dentin, which is much softer, you can have attrition down to dentin, and now acids are starting to dissolve it. This is actually a combination. This one's a combination of attrition and erosion. So you can have more than one present. If it's just flat, it's attrition only. If you wore it flat and then it starts cupping out, then you have both attrition and erosion. So the one on the right is attrition, and the one on the left has a lot of erosion too. Abrasion and abfraction. Sometimes difficult to distinguish, sometimes not. We use the term abrasion when we have an abrasive factor that mechanically wears away tooth structure, and that is not related to tooth contact. So it's not a physiologic process. It's some external abrasive that wears away mechanically tooth structure. And it can be anywhere depending on what the source of abrasive is. And I have some examples, and we'll think about what has worn away the tooth structure. One of the most common causes of abrasion is toothbrush. And is it really the toothbrush? Maybe yes, maybe no. The pressure and the toothpaste. So you put a medium to firm toothbrush together with an abrasive toothpaste, and you can cause quite a bit of wear. And that abrasion is going to usually be at the softest part of the teeth, which is the cervical area, in an adult who has some gingival recession and cementum is exposed. When we have toothbrush abrasion, it should be rounded out. It should be rounded out. Then there's that whole dilemma with abfraction. So if you discussed abfraction, we had a CE course here once, and I loved the title of it. It was Abfraction, Fact or Friction. I loved it. I loved it. So it's debatable on if it even exists, but we believe abfraction exists and occurs at teeth with abnormal physical stresses that flex the tooth just enough to break the mineralized crystals in the cervical area so they wash away easily. In which case you get sharp V-shaped wedges in the cervical area. Not gently rounded out areas, but sharp V-shaped edges. And we do believe that toothbrushing and toothpaste that's abrasive kind of accelerates this, because if you've loosened those crystals but you leave them alone, they could remineralize. If you're flexing and breaking those crystal bonds and then brushing, you're removing the crystalline structure so it can't remineralize. So it's abfraction, even if it does exist, is still probably a combination of abrasion and abfraction.
You said if you leave them alone, they could possibly remineralize.
Right.
For cases such as the dental fluorosis, would adding like a varnish, fluoride varnish, make it worse in some cases? If the problem
Fluorosis?
is fluoride?
We are talking about something totally different than enamel hypocalcification.
This one?
Yes. We're
Right.
talking about the whole structure being gone, not just individual molecules.
I see.
So with enamel hypocalcification, Fluoride varnishes can keep them strong, but a lot of times the tooth is not so hypocalcified that caries is a problem. And with fluorosis, when you replace calcium with fluoride, that provides caries resistance, and you don't need fluoride varnish, period. You've already got tons of fluoride in there. Would fluoride varnish help the person who has abrasion or abfraction in exposed tooth structure? Yes, it could, because what's left can be strengthened. And if we have issues with abfraction, we can put our patients on very soft toothbrushes, on non-abrasive toothpastes like Biotene that has absolutely no abrasive in it, and then fluoride varnishes, and that helps preserve tooth structure. So, depends on what the problem is. You got to have the right diagnosis first in order to approach the best treatment. So on the picture I have here, what do you think we have going on predominantly, abrasion or abfraction? It's sharply wedge-shaped, so it's abfraction. And you notice the tooth with the worst is rotated, next to the worst is also malpositioned. So it has abnormal forces that could cause flexure. My mom has one tooth that's badly rotated, almost like the first bicuspid here, and it has abfraction. It's the only tooth in her mouth with any abfraction. She's in her 80s, and she has probing depths of 2 to 3 millimeters, and almost no gingival recession. It's amazing. All right, so what do you think of these? We're going to start with this one. Is that abfraction?
No.
You notice the grooves in it?
Yeah.
This was a patient who listened to the hygienist who said, "You're not brushing your teeth well enough," and went home.
Went to town.
Went to town. Got a metal brush out of his out of his shop in his garage, and if it's good for cleaning things in my garage, it'll keep my teeth really clean. And it actually, you can see the scoring on the roots from the metal wire brush. Okay, so we can overdo it. Let's make sure we tell our patients what to use to clean their teeth. But that's definitely abrasion and not a natural situation. What about this one? So this is a patient, sharp V-shaped wedge? No, that's a gently curved. That was a patient whose teeth are rotated, a little more prominent right at the midline. Uses a firm toothbrush, abrasive toothpaste, and straight across, and it's just wearing a flat plane from brushing. Notice how very smooth and shiny the rest of the teeth are, and those natural little ridges are all gone. There's quite a bit of abrasion there from very heavy toothbrushing. But there's no plaque. No plaque. So, what about this patient? Do we get abfraction at the incisal edges?
No.
It's exclusively in the cervical area of the teeth, so that's not abfraction. It's abrasion, but why is it just little notches at the edges of the teeth? Did you notice that it matches top and bottom? Chewing on pencils. And it's the pencil that's the abrasive thing. So you got to find out what their habit is. What about this patient? It's just this area. Can the tongue wear off teeth? Think about it. No, it's not the tongue. Smokes a pipe. That's where he holds his pipe. Very good. So biting on the pipe handle was enough abrasive to wear off the teeth. But it is, that's a pattern of abrasion. So there can be lots of interesting things. Yes?
For this picture, why isn't it abfraction?
Because abfraction makes a sharp, smooth, V-shaped wedge, not a more rounded area with lines that are scoring across it. So abfraction is a very predictable appearance. So yeah, patients work overtime to do interesting things to their teeth sometimes. This is erosion. The top one is an extreme case. Erosion is the term that we use for acid dissolving to structural enamel first, and then dentin if you get down to it. And it is non-bacterial sources of acid. So it's not the karyogenic flora that make acids that demineralize teeth and lead to caries. It's other external sources of acids. One of the more common ones that we see sometimes, depends on the region and the culture, but is lemon sucking. Some people love the taste of lemons. Some people salt their lemons even, but they bite into them and they hold them there because they like that sour. Lemons will really dissolve your teeth. I have a good friend who used to do the lemon thing every single day. I was in dental school and I told her, you can't do that anymore. You have beautiful teeth. They won't stay that way. So, but we can also get acids from other sources. Chewable vitamins, including the very popular chewable gummy vitamins. If they have vitamin C, they're acidic.
What about lemon detox, like, liquid one?
Lemon detox, liquids. Liquid drinks that are high acid can cause some erosion of the teeth, but they're not going to produce it in this pattern where it's just a localized area. It's going to be more general dissolution, and that includes sodas that are very acidic, iced tea that has a lot of lemon in it, a lot of salad dressing, vinegar. And some people drink the apple cider vinegar every day because it's healthy for you. You just have to be careful. If you really like the apple cider vinegar and some of those detox things, drink it with a straw so it goes right down your throat, not on your teeth. But most of us like the taste from the acids. It gives it the sour kick. It's kind of good, so just don't do it every day. If you do the lemon sucking, it can actually prep your teeth for the crowns that you will need for restoration and replacement of the lost tooth structure. One of the ones that we worry about is regurgitation of stomach acid. This is an issue for patients who have bulimia, which is an eating disorder where they binge and purge. They throw up what they ate. What they ate has stomach acid in it, and so every time they throw up, we get a little bit of erosion on the teeth that the food contacts on its way out the mouth. So where are we going to see the erosion from bulimia? The lingual side of the maxillary anterior teeth. In long-standing cases, we can even get lingual side of the bicuspid and molars. But usually the lower teeth are protected by the tongue being present, and so it's usually just the upper teeth. But we can even remove the entire incisal edge of those incisors. So then you need lingual veneers, porcelain veneers on the teeth. Another one that is getting to be more and more prevalent is stomach acid that is regurgitation because of gastroesophageal reflux disease. And people who have reflux of stomach acid, it is often something that happens at night when they're asleep and they're not aware of it. If they sleep on their side, we get erosion on the buccal surfaces of the teeth on that side, particularly cervical areas. If they're exposed, there can be the whole sides. If they are a back sleeper, it tends to puddle in the back of the mouth, and we see it more on the buccal sides of the lower molars. The other lower teeth tend to be protected by the tongue, sometimes the lingual surfaces of the maxillary molars. So the location of the erosion gives you a clue as to what might be the source. You ask your patient questions, and that helps confirm it. Dentists who work with patients who have dental erosion should not restore the teeth until the source of erosion has been stopped. So failure to diagnose means your restorations are going to fail for the same reason the problem was there to begin with. So it's something you have to pay pretty close attention to. When it's just really localized, that one's a harder one. Usually the distribution, you should have a pretty strong suspicion what the source of the problem is. So for testing purposes, are we going to tell you what the source of the problem is? No. You know us. We expect you to read between the lines and have a best guess based on the distribution. That means we're going to have to give you cases where it's reasonable that you would have a suspicion of the right thing. Like the lemon sucking, where the whole anterior upper teeth where you bite into the lemon are gone, or the classic distributions for bulimia or something like that. So this is one from bulimia. I mean, not bulimia, GERD. This is GERD, where it's puddling in the mouth. And now the amalgams are standing up above the top of the tooth because the tooth has dissolved away. Do you think this one fits with bulimia?
Yeah.
But it's just part of the tooth. If it was bulimia, it would be from tip to stern. So that's from wearing away, from abnormal contacts. They have a malocclusion, and they have really heavy wear, just locally on the lingual of those incisors. So you have to think about it, not just look. Anytime we have missing tooth structure, you have to think, does it fit with wear? Does it fit with acid dissolution? Is it a mechanical abrasion? You have to think about it. What about this one? See, this one fits nice classic patterns for bulimia, where it's the lingual side of the maxillary teeth, worse in the anterior region. This is a long-standing case, so it even affects the lingual side of the molars. And you can see how it shortened the incisal edges as well. Question?
So for testing purposes, would you want us to put erosion or bulimia?
It depends on the question. If we ask for the diagnosis for the tooth, the diagnosis is erosion. If we ask for the underlying cause, then we want bulimia. So you've got to read your questions. We had a quiz question last week that more than half the class missed because they answered their wrong question. They gave the diagnosis and the question was, how do you manage it? So you got to read the question. Don't jump the gun. Say, oh, I know what this is. Read the question, answer the question. And then you'll get it right. So we move on to resorption. Resorption is the term that we use for removal of tooth structure by physiologic processes, which means the part of the tooth that's being resorbed has to be embedded in tissue. Sometimes it's a completely unerupted tooth that is resorbing. Sometimes it is resorption in a root of a tooth that's still in there. But a key feature of resorption is that the part of tooth that's missing is not exposed to the oral environment. If it's exposed to the oral environment, it has to be something else. We have two different patterns of resorption. We have internal resorption and we have external resorption. Internal resorption means the resorption is occurring from the pulp space inside of a tooth, from the inside, and can work its way out. External means it's from the outside of the tooth working its way in. And some types of resorption are fairly common and some are uncommon. This is internal resorption right on the inside. Single most common cause of internal resorption is inflammation, pulpal inflammation, and eventually necrosis. And if we catch that pattern of internal resorption early enough, those teeth can be saved with endodontic treatment. A little bit challenging to instrument and fill, but it can be done. Sometimes we have generalized internal resorption, multiple teeth, particularly in the pulp chamber. That can be due to a metabolic problem. That's very rare. It can also be hereditary. It can have a genetic basis, and nobody knows what's really going on in these familial cases, but we definitely have familial cases, and it's adult, often middle-aged adult onset, where an internal resorption starts developing one tooth by another, and eventually it affects all the teeth. And if you catch it early, before too much tooth structure is destroyed, you can do root canal therapy to stop the process. But it's a costly treatment because you end up treating your whole dentition eventually. This is a case of internal resorption that was caused by a neoplasm. Cancers can invade the pulp space and cause internal resorption of the teeth. But you'll notice the widened PDL around and also some destruction of the bone. So I guess it's probably not a surprise that that's a malignant neoplasm. And the teeth are mobile, and that's one of the signs of malignancy in the bone too. So that's a hard one. Might not show you one of those. But it can happen, and you should have a high level of suspicion of neoplasm and not inflammatory process when it's more than one adjacent tooth and it's down in the root and there are bony changes as well.
Are those generally local tumors, or are they metastatic? Or we can't tell?
Are they primary tumors or metastatic? It could be either one, but both of them are localized. You're not going to see this on every tooth in the mouth. It's going to be some adjacent teeth that are together in one place. It's very uncommon to have more than one metastatic focus in the jaws, even though we can have multiple metastases to the body. Having more than one site of metastatic tumor in the jaws is very, very uncommon. Anybody know what is the physiologic source of internal resorption for this tooth? Look carefully and think about it. It's pink because it's full of tissue. It's just a shell of a tooth. That's all that's left. Just a shell of a tooth.
Is it growing? The tissue's growing into the tooth?
Is tissue growing into the tooth? Kind of, yes. Nobody has a clue what that one is? No, it's not chronic hyperplastic pulpitis. That would have huge caries at the occlusal or mesial or distal surface. There's no caries with this tooth. Nobody knows what this one is?
Just tell us.
This happened to every single one of us. This is normal resorption of the root as the tooth exfoliates, and sometimes if you just keep that tooth in really long instead of the kid wiggling it and pulling it out, it will resorb even the crown of the tooth, not just the root. So that's just physiologic internal resorption from normal exfoliation of primary teeth. See, you didn't figure out that was primary tooth. Primary second molar looks like permanent first molar, only a lot smaller.
It would have mobility, right?
Oh yeah, it would have mobility.
Yeah.
But some people don't, some kids don't like to wiggle their teeth. I don't get that, but anyway. This one is a pink tooth of mummery from internal resorption on a permanent tooth that's working through to the surface so you can actually see pink through. Forensically, there's a different pink tooth of mummery that's generalized discoloration of the teeth from a certain source of poisoning that kills people. They look for that when they're determining cause of death. That's not what this is talking about. This is internal resorption working its way through the surface. If that one's going to be difficult to treat and manage because it's almost all the way through. One of the most common causes of external resorption of roots of teeth is trauma to teeth that avulses them and the tooth is reimplanted, or partially avulses them and the tooth is repositioned. That can cause damage to the periodontal ligament, and we can end up with external resorption over time. It can be quite large. This one, you know, has a history of trauma because they did the root canal therapy trying to get on an immature tooth, trying to get the root end to close. This one is just one tooth with really excessive external resorption and other teeth with moderate. Anybody know what that's from?
Braces?
Braces. Moving the teeth too rapidly for orthodontic treatment. Yeah, so you got to be careful with that as well. So.
Is it because it's moving too fast?
Yes, it's moving too fast and we get resorption of the root as it moves. Even slow movement of teeth usually causes a little blunting of the apex, just slight though. But notable resorption is moving the teeth too fast. This one is resorbed because of a malocclusion. The tooth was tipped and then was just the one tooth pulled back into position too fast. What is this one?
Wow.
What do you think? Is that external resorption or is this something else? What do you think?
No.
Decay. So this is exposed to the oral environment through the sulcus, and it's harder to keep clean because of the impacted tooth, partially impacted tooth, part of it's erupted, and so that's actually caries. So it needs to all be underneath the surface where there's tissue next to it, not just a sulcus. So this one would not be external resorption, that's caries. But if the impacted tooth is down low, then it could be internal resorption or external resorption. It's very common to get external resorption on impacted teeth that have been impacted for many, many years. The follicle breaks down over time and the tooth is remodeled along with the bone around it, and we get external resorption. So this one started out with external resorption and then eventually communicated with the sulcus, and we've got some infection going on there because we've got infection from the periodontal sulcus. So that's a complex problem. I can't show you that one. I'll have to show you a simple one on an examination. We move into environmental discoloration of teeth, stains. I have a study PowerPoint, but I don't have really good examples for stains that are published. So it's important that you pay attention in class to our stains. Extrinsic stains are the ones where the stain is deposited on the outside of the tooth and you can polish it off. Intrinsic stains are ones where the stain was incorporated in the tooth during tooth development and it doesn't polish off. It is part of the tooth. Usually we can distinguish intrinsic from extrinsic stains. The patterns and colors and distribution of the stains will tell us what the specific diagnosis is. Common sources of extrinsic stains on teeth are tobacco, number one. Smoked tobacco stains the teeth a lot. Other forms of tobacco, not so much. Sometimes bacterial product, chromogenic bacteria can produce colored substances that deposits on teeth. Food, coffee and tea. Tea is my vice. I have black staining in all my pits and grooves from my tea where it won't polish off. Gingival hemorrhage, blood from the sulcus in patients with periodontal disease, even just micro leakage can produce some extrinsic stains. Vitamins that have iron, medications that have minerals in them. Chlorhexidine, how many of you have seen chlorhexidine staining already on your patients? So we use chlorhexidine for what purpose? To discourage the growth of our periodontal bacteria and control periodontal disease. And we use it in patients who don't brush and floss very well, but when they don't brush and floss very well, that bacterial plaque on their teeth picks up brown stain from the chlorhexidine. It can even stain the soft tissue. So you have to tell them this will help you, but you still have to brush or your teeth turn brown. Yeah. Anyway, intrinsic stains we'll talk about when we get to them. Tobacco. Do I have to tell you that they're using tobacco product? No, because they have some nicotine stomatitis. But tobacco stains tend to be broad, very dark brown to black. If it gets into dentin, it will not polish out, but it can be throughout the dentition. And it can be really light or it can be pretty heavy. But often we have other clues that the patient is smoking. So that one's easy to figure out. There's our peridex staining, all the areas that have heavy plaque. And even the papillae on the tongue can stain with peridex. I love that. This was my patient on the left, and she had a very painful gingival condition that made it hard for her to brush. So we were using peridex on her, but she didn't like the staining, so she quit using the peridex. Look at her gingiva. What disease do you think she has? Review time.
No, gingivitis. Contacts.
Contact stomatitis, we would have gotten rid of it. This is a chronic disease. Sometimes it blisters.
Biggest.
None doesn't blister.
It's not.
It's going to be one of the diseases that produces that desquamative gingivitis pattern. So,
It's gotta be,
do you see any striae there?
no?
She did not have erosive lichen planus, although that's probably the most common cause of desquamative gingivitis. She has mucous membrane pemphigoid. She was my mucous membrane pemphigoid. The gingiva tends to be very red, but it looks stretched and a little bit slick a lot of the time. This is brown stain. Brown stain we tend to see in patients with pretty good oral hygiene, so not a lot of plaque. And we see deposits particularly opposite the salivary orifices. So we see the most on the lingual of the mandibular incisors and buccal of the maxillary first molar, second molars. But we can also see a thin line on the lingual surfaces. Except for the lower anteriors, it tends to be a very thin line with a slight gap between the gingiva and the line on the tooth. So the discoloration doesn't go all the way to the gingiva. It does polish off. You might have to polish pretty hard, but it does polish off. But it tends to be seen in patients with pretty good oral hygiene. So that's a classic brown stain. Sometimes we see black stain. It tends to be a heavier, darker line than brown stain and tends to be more generalized, not in the locations opposite the salivary gland orifices, and is substantially less common than brown stain. But would we get brown stain on the buccal surfaces of the mandibular teeth? Never, virtually never. And so this is a nice example of a black stain, a little wider, a little darker, a little bit different distribution than brown stain. A little harder to polish off, but does polish off, but it's pretty tenacious.
Dr. Richard?
Yes?
The black stain, is it like going to be the same as the brown one? It doesn't go all the way down?
Sometimes it goes all the way down, sometimes there's a gap. We see it both ways.
Okay, so...
But it's never the really thin, delicate line. It's always a wider band, a little bit wider band, and darker, and the distribution is the biggest clue. It's not opposite the salivary gland orifices. We are out of time, so we will pick up here when we meet again on Friday.
No, brown is opposite the salivary.
Oh yeah, Dr. Richard, Sandra has I don't know.
No, just brown. Although we can add some of these if you want, it might make it easier.
Yes.
I noticed you really struggled with the jaw thing on our last quiz, so. Gotta follow the process. We learn the process.
I'm just kidding. I think I'll be good. I just have to do it. You're what? What's the plan? We were going to
Why do you guys have the same name? It's just so wrong. It's so right though. It's such a good name. What? We didn't know each other until
I was looking for her on the first day of orientation.
Where is she? She better be here. I have a message for her.